Hello everyone. In today's class, we shall discuss about the alveolar bone. So here we are going to go through the definition, development, parts of the alveolar bone, its composition, the cells involved in the formation of alveolar bone, the bone formation, bone resorption, functions, and we shall discuss in the end about the variations which occur in the alveolar bone and conclude. Okay. So let's start with the definition. The alveolar bone is that part of the maxilla or mandible that supports and protects the teeth. So this is what the alveolar bone comprises of. So let's start with the development. The development of alveolar bone starts during the second month of fetal life, both in maxilla as well as mandible. Here, initially it forms as a groove which contains the tooth germ, the alveolar nerves, and the tips. So between these two germs, bony septa develop, and they actually differentiate the different tooth germs and their future location in each individual. And also there is a primitive mandibular canal which is separated from the dental crypt by a horizontal plate of bone. So as the alveolar process develops, its completion occurs only after the eruption of the tooth, that is after the birth of the individual, which is the initial development of primary teeth usually starts from 6 months. So the completion of the alveolar process development occurs only after the eruption of teeth. Now coming to the parts of the alveolar bone. The alveolar process usually consists of the following parts. That is, it comprises of an external plate of cortical bone, then inner socket wall of thin compact bone, also called as alveolar bone proper. Then it contains cancellous trabeculae as well as basal bone. So now let's see what an external plate of cortical bone is. It's mainly formed of Haversian bone and compacted bone lamellae. Whereas the inner socket wall of thin compact bone called alveolar bone proper, which is usually seen in radiographs as lamina dura, occurs adjacent to the tooth, that is, it forms the socket wall. Then cancellous trabeculae, that is between these two compact layers, that is external plate as well as the inner socket wall, we have the cancellous trabeculae, which acts as supporting alveolar bone. Now coming to the basal bone, this is that portion of the jaw which is located apically, and it's usually unrelated to the teeth. And this forms the basal bone. Here you can see the separation. Here the upper section which contains the teeth comprises of the external plate, the inner socket wall, and the cancellous trabeculae, whereas the portion below is the basal bone. Now coming to the discussion in detail about each parts, that is, let's first discuss about the external plate of cortical bone. Now the thickness of the compact cortical bone will differ depending upon the location of the tooth, the angulation of the tooth, and the position of the tooth in the both in the maxilla as well as the mandible. So in case of canines and premolars, the cortical plate is usually thin in comparison to the coronal parts of the roots. And in case of tipping also, when the tooth has a labial tip, the cortical plate will usually be thinner on the labial side in comparison to the lingual palatal process, where the cortical plate will be thicker. So coming to the alveolar bone proper, this is called is also called as the bundle bone. The name bundle bone is given mainly because it has numerous bundles of Sharpie's fibers which are passed from the periodontal ligament into it, and the radiographic term lamina dura is given to the dense white line which is seen on radiographs, which defines the alveolar bone proper. And the earliest radiographic change which denotes periodontitis is seen when the continuity of the lamina dura is lost at the proximal aspect of the crest of the interdental surface. So this is the first sign of periodontitis in any patient. Now coming to the cancellous bone. Here the cancellous bone consists mainly of bones which are of lamellae, which are arranged to form a trabeculae, and they usually arrange in a random fashion, and these trabeculae usually surround narrow spaces. As the name suggests, the bone contains numerous hollow spaces, that is marrow spaces, and these medullary cavities are usually filled with marrow. This is the red bone marrow, which is active in the production of blood cells. As the person ages, this marrow starts turning into yellow, which is mainly because of its conversion into a fat storage site instead of an area where blood cells are produced. So the arrangement of trabeculae can be divided as two types. Where type 1, please excuse me, the radiographs are not clear. The type 1, where you have the regular and horizontal ladder-like arrangement of the trabeculae, and type 2, where you have irregular arrangement of trabeculae. So in the first radiograph, if you look at it carefully, you can see the ladder-like arrangement of the trabeculae, and the second radiograph, you have irregularly arranged numerous delicate trabeculae. Then the next portion is the interdental septa or interradicular septa. So we've gone through the cortical plates, the cancellous bone. Now let's look into the interdental septa or interradicular septa. So the bone between the adjacent single or multi-rooted tooth is known as the interdental septa, and mainly consists of cancellous bone, which is bordered by the socket wall of the approximating teeth and also the facial and lingual cortical plates. So this comprises of the interdental septa, whereas the interradicular septa is the bone between the roots of multi-rooted teeth, and both these septa contain perforating canals of Zuckerkandel and Hirschfeld, which are the nutrient canals. These canals give the nutrients to the alveolar bone. That is, they are the main channels of blood supply. Now coming to the basal bone, it is the osseous tissue of the mandible or maxilla, which does not involve the alveolar process. So anatomically, there is no distinct boundary for this alveolar process and the body, the maxilla or mandible. That is the basal bone. So coming to the maxillary alveolar process, let's see what are the parts of the maxillary alveolar. Consists of both buccal and palatal alveolar plates, between which lie the sockets of individual teeth. Then between each socket lies the interalveolar or interdental septa. Then we have the floor of the socket, which is known as the fundus, and the rim of the socket, which is termed as the alveolar process. The same terms apply for the mandibular process, right? And as we all know, again, mandibular alveolar process also contains the buccal and lingual alveolar plates and the interdental and interradicular septa. So the form and depth of each socket, both in the mandible and the maxilla, is related to the morphology of the roots of the teeth present in the respective areas. So now let's have a look at what the other parts are. The periosteum. The periosteum is seen in the outer surface of bone, and the periosteum is again divided into two layers of specialized connective tissue. What are the two layers? The outer layer or the fibrous layer is mainly formed from dense collagenous fibers and fibroblasts, and the inner or cellular or cambium layer contains functional osteoblasts, they are precursors, and it has a rich vascular supply. Here you can see a picture of the periosteum with its rich vascular supply. So the periosteum is very important for the growth, regeneration of periodontal defects and healing, which involves both healing after periodontal surgeries as well as implant placement. So this periosteum plays a very important role. Now coming to the endosteum. So the medullary cavity and spaces within the alveolar bone are covered by a layer known as the endosteum. This endosteum is very thin and delicate, and it consists of a membrane which contains a single layer of osteoblast, and its architecture is similar to the cambium layer, which is the inner layer of the periosteum, and because it has osteoprogenitor cells. So these osteoprogenitor cells are those cells which can differentiate into any type of cell which is that is according to the requirement of the area. So whichever cell is deficient, it can transform itself into those cells, be it osteoblasts or osteocytes or osteoclasts. Now coming to the bone organization. So what is this compact bone composed of? So the different arrangements in the bony layers in the compact bone. So in the compact bone, the deposition is deposited in the form of lamellae, which are arranged in parallel layers, both in the periosteal and endosteal surface. When it is arranged parallelly, this type of arrangement is known as circumferential lamellae. Now, around the vascular canals, that is where the blood supply occurs, around the vascular canals, also known as Haversian canals, we have the bone deposition in a concentric fashion. So here, the lamellae is known as concentric lamellae, and the lamellae in between these two layers is also known as interstitial lamellae. And the Haversian canal, together with this concentric lamellae, is known as the Haversian system, or it can also be called as an osteon. And besides these Haversian canals are interconnected with each other with the help of transverse Wolfman's canal. In the picture, we can see a Haversian canal in the center marked as A, and we have the interstitial lamella around it. Now coming to the composition of the alveolar bone. The alveolar bone has two basic constituents. It contains cells as well as extracellular matter. Now what are these cells? The cells are osteoblasts, osteoclasts, and osteocytes. Besides, we also have the osteoprogenicism, that is cells capable of differentiating themselves into any of these cells. And then we have the extracellular matrix. Now, extracellular matrix can again be divided into two types. That is, this extracellular matrix contains organic as well as inorganic material. This organic material is mainly contains collagen fibers, and it also contains besides collagen, it also contains non-collagenous proteins. The inorganic material comprises mainly of the minerals present in our body, that's elsewhere in our body, like hydroxyapatite, calcium, phosphates, etc. So we just go into the details. That is, the inorganic materials mainly contains calcium, phosphates, hydroxyapatite, carbonates, citrates, sodium, magnesium, and fluorides. The organic constituents, which include collagen and non-collagenous proteins. Collagen includes mainly type 1 collagen, and non-collagenous proteins includes osteocalcin, osteonectin, bone morphogenetic proteins, phosphoproteins, and proteoglycans. Now coming to the cells of the alveolar bone. As we have already seen, it consists of osteoblasts, osteocytes, and osteoclasts. So osteoblasts are basophilic, plump, colloidal, or slightly elongated cells, and they contain rough endoplasmic reticulum, numerous mitochondria, vesicles, and Golgi pumps. They mainly produce this type 1 collagen. Then, besides, the osteoblasts also produce non-collagenous bone proteins like styloprotein, osteopontin, and osteonectin, and also contribute to the production of growth factors like bone morphogenetic proteins, transforming growth factor, insulin-like growth factors, platelet-derived growth factors, and fibroblastic growth. So coming to osteocytes. These osteocytes are actually cells which lie within the bone itself and are also known as entrapped osteoblasts. So they occupy spaces or lacunae in the bone and are defined by the cells surrounded by the bone matrix. These lacunae are usually regularly distributed, and they usually have a number of fine canaliculi which radiate from them in all directions. And as we have already seen about the osteoprogenicism, these are the stem cell populations which can differentiate themselves into any type of cells, and they are usually fibroblast-like cells, and their life cycle may involve up to 8 cell division before they reach the osteoblast stage. So they reside in the layer of cells beneath the osteoblast layer in the periosteal region, and they are found also in the periodontal ligament and also in the marrow space. That is, those areas where there is a rich nutrient supply or vascular supply. Now coming to osteoclasts. Osteoclasts are large multinucleated cells, and they are mainly responsible for bone resorption. And these osteoclasts also lie in resorption base called Hauschig's lacunae. And the one characteristic feature is that they help in bone resorption, and at the time of resorption, they occur with a ruffled border, and this ruffled border is known to secrete certain enzymes which help in the osteoclastic activity. Then the osteopontin and bone siloprotein which are produced are also known as cell adhesion protein, because they help in adhesion of these cells. And also, besides, there are also other paracrine factors involved here, which include cytokines, chemokines, and growth factors. And all these factors play a predominant role in the development of the alveolar process. So, coming to the process of bone formation. As the bone formation progresses, the osteoblasts will lie in tiny spaces with surrounding mineralized matrix, and these osteoblasts are called as osteocytes. So they absorb the required calcium and phosphorus they require for the bone formation from the blood plasma and also from their nutritional sources. So the main regulators which regulate the bone formation involve hormones as well as local regulators. So the hormones involved are parathormone, vitamin D3, glucocorticoids, thyroid hormone, growth hormone, and insulin. And the local regulators involve platelet-derived growth factors, insulin growth factors, transforming growth factor beta, bone morphogenetic protein, and fibroblast growth factors. So we have two regulators, hormones and local regulators. Now, regarding bone resorption, it is a process of removal of minerals and organic components of the extracellular matrix of bone by osteolytic cells, that is the osteoclast. So there are several methods by which this bone resorption occurs. So this is one of the methods. That is the first phase involves the formation of osteoclast progenitors in the hemopoietic tissue, and which is followed by a second phase where there is activation of osteoclasts at the surface of mineralized bone, and these activated osteoclasts in turn in the third phase resorb the bone. So this is a picture depicting the bone remodeling. Here you see the osteoclast with a ruffled border, and as the bone resorption occurs, it liberates matrix-bound growth factors into the surrounding area. So this in turn will stimulate proliferation of osteoprogenitor cells, and these osteoprogenitor cells, when stimulated, in turn will proliferate and maturate to form osteoblasts. Osteoblasts are bone forming cells, so they in turn will help in bone formation and bone deposition in the area, and after their lifetime, they then with the help that is when induced by mechanical factors, hormones, or cytokines, they in turn act as mediators of osteoclastogenesis. So this cycle keeps on going, whereby the bone deposition and bone resorption is balanced by both these osteoclasts and osteoblasts. So this interdependency of osteoclasts and osteoblasts in remodeling is also known as coupling. So, and the bone matrix which is laid down is usually a non-mineralized osteoid, which later becomes mineralized. So, according to 10K, there are few steps involved in this bone remodeling. That is, initially there will be attachment of osteoclast to the mineralized surface of bone, which is followed by creation of a sealed acidic environment through the action of a proton pump, which demineralizes the bone and then exposes the organic matrix. And then this is followed by a third step, whereby the degradation of the exposed organic matrix occurs, and that is by the action of enzymes like acid phosphatases and cathepsins, and this is followed by sequestering of the mineral ions and within the osteoclastic cells. So these are the steps in which were described by 10K. So and this remodeling mainly occurs in 3 areas. That is, these areas are to be noted. That is, it occurs mainly adjacent to the periodontal ligament, then in relation to the periosteum of the facial as well as the lingual alveolar plates and also the endosteal surface of the narrow space. So these are the three areas where bone remodeling primarily occurs. So the remodeling of bone in turn causes the formation of few lines, that is the resting line and reversal line. So when there is replacement of old bone by new bone, there is a systematic balance of osteoblastic and osteoclastic activity. The bone forming activity is depicted by the intensely dark line, that is the resting line. That is the initial line. You can follow my cursor. This is the initial line. This is the resting line. And resorption activity is seen by the reversal line or dark scallop lines. That is the marked by B. So coming to the functions of the alveolar bone. So as we know, the alveolar bone has several functions. Like it helps in holding the sockets of the teeth. It anchors the roots of the teeth to the alveoli, which is achieved by the insertion of sharp fibers into the alveolar bone proper. It also helps to move the teeth for better occlusion. That is the physiologic movement which occurs during occlusion. It helps in absorbing and distributing the occlusal forces which are generated during the tooth contact. It also supplies vessels to the periodontal ligament. It protects the developing permanent teeth by supporting the primary teeth at the same. So the process by which the blood calcium is maintained through the resorption and bone deposition activity is when there is a decrease in the level of blood calcium. It actually stimulates the chief cells of parathyroid, chief cells of parathyroid hormone, which releases the osteoblast. So these osteoblasts then in turn, in the presence of interleukin 1 and 6 and leukocyte inhibiting factor, will induce the monocyte migration, and this leukocyte inhibiting factor will cause a coalescence of the monocytes, which will form the osteoclast. These osteoclasts will cause bone resorption. So when the bone is resorbed, again it will release calcium into the blood, so thereby maintaining the calcium imbalance. That is, initially the parathyroid hormone was stimulated because of the decrease in calcium. So now the calcium becomes balanced, so thereby giving a feedback onto the parathyroid hormone. So thereby these osteoclasts will cause bone resorption and release of these calcium ions, and which in turn will cause differentiation of osteoblasts, which will induce differentiation of osteoblasts, which will in turn lay down the osteoids or the bone. So this is also a major function of the alveolar bone, which maintains the bone resorption and the bone deposition activity through several regulators, which includes hormones as well as growth factors. So coming to the discussion part, that is the normal scenarios that we come across when we see a case of periodontitis. That is, we often come across the horizontal bone loss, where the crest of the bone is usually perpendicular to the tooth surface. We also come across vertical or angular bone defects, which occur in an oblique direction. Here, the bone loss occurs in an oblique direction. So the bone loss we commonly come across is the horizontal bone loss in periodontal patients. So here we have an X-ray showing the horizontal bone loss and also vertical angular defect. You can see the pattern of bone loss in both the intraoral periapical review. And also the pattern of bone loss will decide the type of architecture present. That is, architecture refers to the relative position of the interdental bone to the radicular bone. What do you call a positive architecture? Positive architecture is when the radicular bone is apical to the interdental bone, and negative architecture is just the reverse. That is, the interdental bone becomes more apical than the radicular bone. And a flat architecture is when both are at the same level. So I have a picture here showing the positive architecture, whereby the interdental bone is at a higher level than the radicular bone, And in flat architecture, both of them are in the same level. And the negative architecture, we see the interdental bone is at a lower level than the radicular bone. Here is a picture whereby you can see clearly how the tooth shows a negative architecture, whereby the radicular bone is at a higher level than the interdental bone. So, the few of the common defects that we come across in the alveolar bone are the fenestrations and deficits. So, fenestrations are actually isolated areas where root is denuded of bone and the root surface becomes covered only by the periosteum and gingiva. Here, the marginal bone is intact. Please note that in case of fenestration, the marginal bone is intact. And this occurs in approximately 20% of the teeth and usually seen in the facial area than the lingual bone. And it's more commonly seen in the anterior teeth than in the posteriors. And also, we see if you look at the picture carefully, you can see there is a tendency for it to occur bilaterally. Both the lateral incisors show a fenestration. That is the trend commonly seen in such defects. And also, dehiscence is when the denuded area extends through the marginal bone, then the defect is called the dehiscence. That is, the marginal bone is not intact, as we see in the sentinel incisors and the canine area. There is loss of marginal. This type of defects mainly occur when there is a prominent root contour, malposition, or labial protrusion of the root, or when the bony plate itself is very thin. So, all these are predisposing factors. So, this is very important. Why? Because we should. This is definitely going to affect the outcome of the periodontal surgery. So, we should have a knowledge of the such defect. Okay. Another type of defect commonly encountered during periodontal surgery is the osseous craters that we come across. This is a diagrammatic representation where we see the normal bone contour on the left side and the defective bone osseous crater on the right. Another type of defective bone contours which is commonly encountered during periodontal flap surgery is the bulbous bone contour, whereby we see a bulbous bone which has to be contoured to simulate the normal anatomy. So, it has to be recontoured to simulate the normal anatomy. And this is another abnormal bony contour whereby the and the condition is normally referred to as an exostosis. This might occur in a generalized manner. It can also occur in a localized area. So, this usually has an idiopathic etiology and does not have a, and not related to any periodontal defect. Another type of bony defect commonly encountered is those seen in deficiencies like osteomalacia, where there's softening or weakening of bones, usually seen in children due to lack of vitamin D. And another condition is osteopetrosis, where there is failure of osteoclast to resorb, thereby causing an increase in the bone density. And another condition whereby the bone gets infected is the condition known as osteomyelitis. Here the infection can occur from a source other than that of the bone. So it can occur via the bloodstream, or an infected adjacent tissue can be the cause of this osteomyelitis. And another condition we encounter in the alveolar bone, that is in radiation patients or carcinoma patients, is osteoradioidectosis, which is an inflammatory condition which occurs when the bone becomes exposed to therapeutic doses of radiation. In case of malignancies of head and neck region, it usually causes an irreversible tissue death, and the mandible is usually more affected than the maxilla. So, with that, we come to an end of today's class. So, definitely we can come to a conclusion that the structure and integrity of the alveolar bone is one of the most deciding factors in the diagnosis as well as treatment planning in periodontal patients, and also patients who require therapies which include replacement of teeth or any other minor defect correction. So, that we come to an end of this class.